So it now gives me great pleasure to introduce Dr. Clifford Lisk, who comes by recommendation. Cliff is a consultant geriatrician at Barnet General and has he has a range of other roles. He's a very busy gentleman. He's particularly interested in postgraduate education of doctors. And I think we're very lucky to have Cliff, because everybody I've mentioned him to says he's a great lecturer. So no pressure, Cliff. And I'm going to hand over to you now. And if everybody who joins, especially if you've got other people in the room, please could you mute your computer so that we can hear everything Cliff has to tell us. Thank you.
Excellent. Thank you very much, Roz. So I'm a geriatrician up in Barnet in North London with a clinical interest in polypharmacy and deprescribing. And really today, I have got some learning objectives for you, definition of polypharmacy and why it's important, why it increases the risk of adverse drug reactions and harm. And by the end of this talk, you should be able to recognize the common prescribing cascades and identify medicines that are more likely to cause problems in your patients with polypharmacy. And really, it's a springboard to start in discussions with patients, carers, relatives, next of kin about medicines they're taking. And then we'll talk about some deprescribing tools that you can use to support your clinical practice. But obviously, your clinical judgment and clinical experience is really important. And to be confident in prioritizing which medicines can be stopped in the dying patient. So I'm going to give the talk in three parts, and they're all color-coded. So we'll initially talk about definition and epidemiology of polypharmacy, the benefits and consequences. We'll touch on adverse drug reactions, and really the common clinical presentations that we see in polypharmacy. And then we'll talk about the prescribing cascade, where you're given medicines to treat the side effects of other medicines. And then we'll go on to deprescribing. What is it? How to go about it? Tools to aid it? Some evidence. And then finally, I'll touch on herbal medicines and physicians' perspectives on deprescribing, as well as barriers to deprescribing. And then we'll do discontinuation syndromes, take-home messages, and I've got some homework for you, and we should have some time for questions. So what is polypharmacy? Well, typically, most papers and most books will define polypharmacy as the concomitant use of 5 or more medicines. But actually, if you're taking, or if you're being prescribed or you're taking more medicines than are clinically required, then that's polypharmacy. So for example, if you're taking amlodipine and you get some leg swelling due to your amlodipine and somebody puts you on frusemide 20 milligrams daily, and that's clearly inappropriate in the absence of heart failure, then that's polypharmacy. If you're being prescribed medicines that do not have a specific indication, that's polypharmacy. If you're being prescribed medicines that duplicate other medicines, so for example, you're being prescribed 2 non-steroidals, so you're being prescribed 2 ACE inhibitors, for example, that's polypharmacy. And clearly, if you're taking medicines that we know is ineffective for the condition you're being treated, that's polypharmacy. And clearly, it has the potential to do more harm than good. And if we look at epidemiology worldwide, 36% of community dwelling older adults aged between their early 60s and mid 80s are troubled with polypharmacy. That accounts for 53% of over 65s in the US and 42% in Canada that take 4 or more prescription drugs. And the National Overprescribing Survey from the UK indicated that 8.4 million people in England are prescribed 5 or more medicines. And clearly, the fastest growing population in the UK at the moment is the over 85s. So it is estimated that almost half of the older population could be affected by polypharmacy by 2030. So whether you're thinking about hospitalizations, whether you're thinking about emergency hospital visits through to the emergency department, there's a huge impact, as you can see. And actually, this study showed that 50% of nursing home residents in the US were taking 9 or more medicines. And when you consider that the average life expectancy is usually a couple of years, we know that the rates of adverse drug reactions are twice as high on those taking more medicines when compared to those taking less. So I like quoting the study. This is a study from Sweden from 2005 to 2008. And actually, if you look on the y-axis, you've got prevalence in percentage, and on the x-axis, you've got years in aliquots of 10 years. And if you look at polypharmacy itself, i.e. the yellow bars, you can see that stays relatively constant between 5 and 10% throughout life. But actually, if you look at excessive polypharmacy, which is 10 or more medicines, which are these blue bars, you can see it continually goes up in 10-year aliquots. And by the time people are in their 90s, the prevalence is of the order of 28%. That's absolutely massive. This is work done by the National Overprescribing Survey, and it looked at the average number of prescription items per head of population from 1994 to 2019. And it wouldn't surprise you to note that in 1994, the average number of prescription items was 9.5, and in 2019, that's 19.4. So that's absolutely doubled in that period of time. So we're prescribing more, patients are taking more. But what about polypharmacy in palliative care? So you can see that it's common due to the fact that patients are often taking medicines for their long-term conditions. They might be taking chemotherapeutic medicines, but also they're also taking an increasing number of drugs for symptom management. And in fact, Sarah et al. Found that the mean number of drugs prescribed for over 4,000 patients across 11 hospices in the US was 15.7. But the range is quite astonishing, from 1 to 100 medicines. And some of these medicines were as required medicines. And similarly, Lundy, when it looked at 138 patients in hospices in Northern Ireland, found that the mean number of medications being taken was 8, with a range of 0 to 17. And that's quite similar to what we find in our older age population when we've looked at this in our hospital in Barnet. This is an interesting piece of work, which was a European cross-sectional study. And apologies for the fact that it's quite small in terms of the writing, but I'll just go through it very quickly. The aim of the study was to analyze the use of medicines and to identify not needed drugs, but also to look at drugs and drug combinations with a risk for drug-drug interactions in a cohort of patients who had advanced cancer. And they looked at all the drugs taken within a study day by cancer patients who were receiving opiates for moderate to severe pain. And they looked at their non-opiates and their adjuvant treatments and unneeded medicines. And there were about 2,000 odd patients from 17 centers across 11 countries, with the mean drug of 7.8, but over 1 in 10 use 10 or more medications. So that's excessive polypharmacy. And the drugs and drug classes most frequently co-administered with opioids were PPIs, laxatives, steroids, paracetamol, NSAIDs, metoclopramide, benzodiazepines, anticoagulants, antibiotics, anticonvulsants, diuretics, and antidepressants. And the numbers varied across countries quite clearly, but approximately 45% of patients received what was defined as unnecessary or potentially unnecessary medicines, and 7% were given duplicate or antagonizing agents. And obviously, these patients were also at high risk of sedation, gastric ulceration, bleeding, neuropsychiatric manifestations, and cardiac complications. So the conclusion was that many patients receive unneeded drugs and are at risk of serious drug-drug interactions. And that's similar to data which we have from older age. I like this slide because it tells you about what the benefits and consequences are. So benefits: improve symptom or disease symptom management. And the good example is probably heart failure. Your patient might be on diuretics. They might be on a beta blocker. They might be on ACE inhibitors. Amongst, that's just 3 of the 5 different medicines that might be on. But actually, if you look at consequences, increased risk of adverse drug interactions, and the more medicines you take, the more likely you are to have adverse drug reactions. Increased risk of drug-drug and drug disease interactions. And we've known since 1992 from Lindsay's paper that this is almost 100% in excessive polypharmacy. Then you've got non-adherence or poor adherence. So your patients have so much to take that they've decided actually they're just not going to take it. Or some of my patients that with dementia might decide to take the color tablets on one day, and avoid the white tablets, for example, because their eyes are drawn to the color tablets. Then we've got inappropriate drug use. Then we've got the risk of the prescribing cascade, where you're prescribing a drug to treat the side effects of another drug. So, for example, somebody's got leg swelling with gabapentin, so you decide to prescribe 20 milligrams of furosemide, even though they don't have heart failure. And we know there are adverse health outcomes, whether you're talking about mobility, whether you're talking about the memory, whether you're talking about nutrition, whether you're talking about self-care, whether you're talking about frailty or mortality. And clearly, this all translates to hospital admissions, but also increased healthcare service use and costs. So the consequences, if you're looking just directly in palliative care, And we see this in older age medicine as well. If patients are taking increasing number of medicines, they might not prioritize the most essential medicines. And actually, they also found that taking more medicines was indeed associated with a higher symptom burden, but they had a lower quality of life. So food for thought for all of us that prescribe. Let me take you back to biomedical sciences, or to medical school or nursing school or pharmacy school, as the case may be. So looking at pharmacokinetics and pharmacodynamics. So pharmacokinetics, so what the body does to the drug, and then pharmacodynamics is what the drug does to the body. And we know in older age, there's a greater trend towards pharmacodynamic sensitivity. And older patients indeed are very, very sensitive to the effects of frequently prescribed medicines that act on the brain. So benzodiazepines, SSRIs. In fact, SSRIs, we know, are an independent risk factor for people falling. Antipsychotics, lithium, increased sensitivity to drugs like warfarin. But what about pharmacokinetics? So absorption is largely unchanged. Body fat increases. Your lean muscle mass reduces, But the thing I want you to concentrate on is really metabolism and renal function. Because with metabolism, your size of your liver reduces, your hepatic blood flow to your liver reduces, your oxidative and reductive reactions, that is how your liver handles through the cytochrome P450 systems, the medication that's presented is reduced. And really important to remember that renal function reduces. And the important thing to look at is the creatinine clearance, not the eGFR. So for example, yesterday on my ward round in the community hospital, I've got a 91-year-old. I said, what was her renal function? Because I was thinking of increasing her digoxin, and digoxin is renally excreted. And said, oh, it's fine. It's 76 mils per minute. And I said, actually, we need to calculate the creatinine clearance. And you can do that on your medical app. And when we calculated the creatinine clearance, it was 31 mils per minute. So we could have doubled her digoxin and put her at risk of digoxin toxicity if we just looked at the eGFR. So you really need to be looking at the creatinine clearance. So just to summarize, as we get older, our brain becomes much more sensitive to the effects of medicines. Medicines stay longer in our body because we have less muscle, we have more body fat. Our liver and our kidneys don't process things as well as they used to when we're younger. Our body contains less body water, very clearly. And so therefore medicines become concentrated. So this is the most important slide around pharmacokinetics and pharmacodynamics. So why do people develop polypharmacy? Well, this is a really important piece of work by Divio et al., which was published way back in the European Respiratory Journal in 2014. So if we look at the y-axis is percentage of patients, and then the x-axis is age in aliquots of 5 years up to more than 85. But actually, if you look at the color codes from 0 to kind of 8 disorders. So if you just concentrate on what you might call mauve, some people will call mauve, some people will say it's violet, you can see as people age, they collect comorbidities. And once they pass this age, they are 64, 65, they collect even more comorbidities. So you can see my patients. So if I take an example from clinic, this past week, I saw somebody who was 90 years old, who had hypertension, had diabetes, had a previous TIA, had heart failure, had restless leg syndrome, had severe arthritis in their knees, had developed a benign essential tremor. So you can see I've already said 7 or 8 things, and I've not even completed the list. So you can see people collect morbidities as they age. That leads to people prescribing, that leads to polypharmacy. Then people get side effects. So people prescribe to treat the side effects of the conditions which you're already treating, which then leads to adverse drug reactions and leads to inappropriate medications. So you can see how that can happen very, 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 very easily. So why are the age group I'm involved with at such high risk? Well, we've spoken about the prevalence of multimorbidity, which leads to polypharmacy. We've spoken about the pharmacokinetics and pharmacodynamic age-related physiological change that happens in all of us, but also increased frailty. So that increased vulnerability, because of reduced reserve in body systems. So very difficult to adapt to change. And so therefore we have increased risk of falls, increased risk of the prescribing cascade, increased risk of memory impairments, increased risk of healthcare, source utilization, morbidity, and mortality. And actually most of our patients are excluded from participation in pharmaceutical research. So therefore, dosing is unclear, side effects uncertain, and effectiveness is ambiguous. So actually, if you're looking in older age medicine, I'm quite fond of saying, actually, apart from the hypertension in the very elderly study, and perhaps the 4S study, for statins in people in their late 70s, early 80s, everything is an evidence-free zone. We're extrapolating evidence. So what I want you to do, whilst I just rest my voice for 15 seconds, is I just want you to put in the chat examples of adverse drug reactions you've come across. And Roz, if you don't mind just reading them out, because I'm a bit wary of kind of opening up the chat so I don't lose stuff. So very quickly over the next 15 to 20 seconds, just give examples of adverse drug reactions you've come across, and Roz will just read them out as you type them in.
So stomach bleeds from aspirin.
Yep.
Drowsy and sick with opioids.
Yep.
Hypotensive.
Yes.
Leg edema from amlodipine.
Yep.
Constipation probably from everything.
Yep.
Falls from benzodiazepines.
Spot on. Spot on.
And confusion, somebody's just put in, probably from lots of things.
Excellent.
Bruising and skin thinning from steroids.
Yeah. Excellent. So really, people are seeing these things, and most of the adverse drug reactions we see either involve the brain, the gastrointestinal system, the urinary tract system, skin changes, for example. So the first line in point of the day, really, if you see anybody with delirium, falls, incontinence, nausea, vomiting, diarrhea, sedation, loss of balance, rash, always have a high index of suspicion that it's been caused by one of the medicines somebody is taking. Because if you don't think about it, you actually interpret adverse drug reactions as your medical condition, which is worsening, or worse, the development of a new disease, and then you prescribe more. So then you use medicines to treat the side effects of the adverse drug reactions, and that results in this, self-fulfilling prophecy of the prescribing cascade. Now, this is a really busy slide. You don't worry, you'll have the opportunity to look at this in great detail. But the point I really wanted to make here is, on my left side, you've got presentations. In the middle, you've got pictures of the presentations. And then on my right-hand side, you've got the medicines that cause the clinical presentations. So as you can see, falls, dizziness, confusion, weight loss, poor appetite, dry mouth, dysphagia, nausea, vomiting, constipation. These are old friends. We see them all the time in our clinical practice, perhaps even daily in our clinical practice. In fact, one of my patients yesterday went on to say, Dr. Lisk, your staff here, they're obsessed about our bowels, about whether we open the bowels or not. This was in the community hospital. So these are things we're seeing all the time. But you can see the numbers of medications that can cause problems. So just look at delirium, for example. It can be caused by anticholinergics, anticonvulsants, things like Buscopan, in terms of antispasmodics, opioids, sedatives. Look at dry mouth, anticholinergics, antihistamines, clonidine, loop diuretics. Look at constipation, anticholinergics, calcium channel blockers, opioids, tricyclics. So the point I really want to make is, when you have people present with the symptoms, ask yourself, is it one of the medicines that I'm giving that's causing this problem? Or is it one of the medicines that my patient is taking that's causing this problem? Because if you do, you will prevent harm and you'll do a good thing for your patients. Okay, so that's the second landing point of the day. And then I want to talk about the prescribing cascade. So this is where we treat the side effects of medicines with other medicines. So the one that really gets on me is amlodipine and edema. Then people given 20 milligrams of furosemide, and then you convert an older person who was just about managing to make the toilet to now having urgency incontinence, and then she falls and fractures her hip. Then now she needs vitamin D, she needs bisphosphonates in addition to everything else. Or donepezil, dementia treatment, they develop some urgency. You think, oh, well, let me give some anticholinergics. And then cholinesterase inhibitors, anticholinergics cancel out each other, so the patient doesn't get any benefit at all. Or antimuscarinic agents like amitriptyline, or vasodilators or diuretics or beta blockers causing dizziness because of low blood pressure or postural hypotension. And then you give Stamitil. because you think it's labyrinth. The patient is complaining of dizziness. Meclizine is kind of a similar drug to Stemitil that's used in the States. Or thiazide diuretics causing gout, or amitriptyline causing urinary retention. And then the patients, nobody examines to see whether they've got an enlarged prostate or not. So think, yeah, you're a guy, you're in your 70s, you must have an enlarged prostate. Let's give you some tamsulosin and finasteride. So you can see how the medicines can subsequently ramp up pretty quickly. And this is a really good paper. This is just for reference by Barbara Farrell, who is basically leads the Deprescribing network in Canada. And they've done this paper kind of blurry, talking about prescribing pathways. So you can see anticholinergics causing sedation and then causing agitation, then somebody needs sedation, or tricyclics or benzodiazepines causing memory impairments, and people get prescribed the cholinesterase inhibitor, or the cholinesterase inhibitors themselves causing anorexia and weight loss, and then people prescribing appetite stimulants. And this one happened to my mother. She had gabapentin for sciatica, and then she developed the most horrendous leg swelling. It was absolutely amazing. And her doctor back home wanted to give her diuretics. And I said, no. I think what we need to do is wean you off the gabapentin. And now her legs are completely back to normal within 4 weeks of stopping her gabapentin. So you kind of get what I'm driving at in terms of the prescribing cascade. So prescribing, it's a really important role. And if we prescribe, we need to learn how to deprescribe. That's really important. So that brings me very nicely onto deprescribing. What is it? So it's this systematic process of identifying and discontinuing medicines in which the existing or potential harms outweigh the existing or potential benefits. But it's within the context of that patient's care goals, their current level of functioning, their life expectancy, their values and preferences. So I like saying when you're talking about deprescribing, you need to do it within context of what matters to the patient. Okay, so for example, I had somebody who was dying from metastatic ovarian cancer who had atrial fibrillation, and we were having a discussion about her medicines. And she says, Dr. Lisk, the one thing I'm really afraid of is having a stroke. So I said, that's fine. I will keep your apixaban going until, or if we get to a position where you're unconscious and you have no need for it. She says, yes, because I really want to be able to converse with my family. So some of this has to be individual decisions. And that's why communication is so important. It's not like, oh, in all 90-year-olds, we should stop there. We should stop a particular medicine. No, it's not like that. Okay. What's the other definition by Scott et al.? The process of withdrawing, dose reduction, or substituting an inappropriate high risk or necessary low benefit drug, supervised by a healthcare professional with the goal of managing polypharmacy. But it's also relevant for those who don't meet the 5 or more definition for polypharmacy. Because as I said, if you're on amlodipine and you don't have heart failure and somebody prescribes, a diuretic for you to help your leg swelling, then that's polypharmacy. You're taking one drug too many for the wrong indication. So if we prescribe, we must be able to deprescribe. And deprescribing, this is just some data from PubMed, the explosion in articles on deprescribing when you look at pre-pandemic and post-pandemic. It's absolutely amazing, the number of articles on deprescribing. So what are the kind of tools, that we have for deprescribing? So you can have what we call an overall approach. Then you've got some implicit frameworks, you've got some screening criteria, you've got some patient engagement tools, you've got some decision support tools, and you've got some medication-specific tools. But you got to assess your patients. You need to look at their medicines. You need to make sure you have their medicines, a full list of their medicines. And this includes over-the-counter medicines. This includes herbal medicines. Then you want to engage them and their caregivers, their next of kin, their carers. And then you need to, after you've judged whether medicines are deprescribing candidates, then you need to prioritize them according to what matters to the patient. And then you develop and implement that plan. That's really important. So I'm going to tell you what I do. So my letter says to patients when they're coming to clinic, please bring all the medicines you're taking in a bag. It doesn't matter if it's a brown bag, a rucksack, a suitcase, just bring them because I want to know what you're taking. And one patient says, well, I take too many medicines. So what they did was to collapse the boxes of all the medicines, put a rubber band around it and brought it to clinic. Very ingenious. Don't forget over-the-counter medicines. Don't forget herbal medicines. Don't forget creams, eye drops, ear drops. Really important. So this is a typical patient. They brought that in a brown bag. And this is my clinic table. And I turn them all onto the table so I can see exactly what my patients are taking. And then I review all the patients with all the medicines with the patient. Identify those that I think are offering benefits and those causing harm. I look at medicines. Are there medicines the patients would like to stop because they're getting side effects? I look for potentially inappropriate medicines, what we call PIMS for short, PIMS. I look for medicines that actually lack an indication. I look for medicines that don't provide any additional benefit. I look at those that actually the patient might need to live for 5 to 10 years to develop an effect, and maybe they've got a life expectancy of 6 months. And I try and avoid complex dosing regimens. So I try and simplify stuff. So if you're on 3 times a day captopril, I try and reduce it to once a day ramipril, for example. So you want to identify any inappropriate, unnecessary, or harmful medicines and prioritize medicines for deprescribing. That's really important. And then there are a number of tools, okay? And I've put some links here on this page to articles that I think you'll find really useful, okay? And I'm going to go through, in my next slide, I'm going to tell you the specific tools that I'm going to cover in this presentation. So this slide is just for reference for you. So what tools am I going to talk about? I'm going to talk about the ACB calculator, the anticholinergic burden calculator. I'm going to talk about the Ottawa Top 10 tool. I'm going to talk to you about the Bears list. Actually, it's Bears list from 2023, not 2019, 2022. I'm going to talk about deprescribing.org. I'm going to talk about medstopper.com, which is the one I use in my everyday clinical practice. I'm going to talk about StatStop and StopFrail. And in case you're wondering why I've got so many knives on the table, this is my kitchen top. At home, I didn't realize I had so many knives, but this is the surgery that we do as geriatricians. This is cutting. We cut medications with a knife. That's why that's the significance of the knives in this slide. So let's go first with ACB calculator. So ACB, if you do ACB calculator, you Google it, it'll come up. And then you put in the drug, it will tell you what the anticholinergic burden score is. And there's a huge list of drugs that have an anticholinergic burden. And it might surprise you, but furosemide itself has an anticholinergic burden score of 1. But the important thing to remember here is the number 3. If your patient scores more than or equal to 3 on their anticholinergic burden calculator, and they will, if they're on amitriptyline, they're at higher risk of delirium, they're at higher risk of falls, and they're actually at higher risk of dying. It's crazy, isn't it, when you think about it? Okay. So we need to be careful when we're looking about anticholinergic burden. And then we've got the Ottawa Top 10 tool. And I've been talking for ages that we need to develop a London Top 10 tool. And maybe you need to have maybe a palliative care Top 10 tool, for instance. So these are drugs, if you're over the age, medicines over the age of 65, in Ottawa, they say, please do not prescribe this to our patients. If you do, you have to have a very good reason for doing so. So anticholinergics, for obvious reasons, the anticholinergic burden, which puts you at risk of falls, puts you at risk of delirium, puts you at risk of dying. Tricyclic antidepressants, they cause a whole lot of problems, including cardiac conduction defects, tachycardia, they cause postural hypotension. Benzodiazepines, it's the drug that I find the most difficult to wean patients off. You get them down to the last, dose of the medicines, and then you struggle to get them off completely. So the best thing is don't start it if you don't need to. The older SSRIs and NDIRIs like bupropion, because they cause confusion, they cause delirium. Antipsychotics in dementia for obvious reasons. Digoxin in a dose of more than 1 to 5 micrograms daily. Why? Because digoxin is renally excreted. So if you assume all your older patients have CKD, then if you go above a dose of 1 to 5 micrograms daily, you are putting your patients at risk of ditch toxicity. And then the urological spasmodic agents, because they've got a high anticholinergic burden. Then stimulant laxatives like Senna, you're not meant to use them long term, because what they do is eventually they cause bowel atony, and then they cause problems with electrolytes, low potassium, low magnesium, for example. And then the long-acting superinurans and glitazones, because they cause prolonged hypoglycemia. And then NSAIDs for a number of reasons. They cause GI bleeding in my group of patients. They cause heart failure. They cause renal failure. They cause problems with the liver. They cause leg edema. And then people get given diuretics for etc. And then you've got the StatStop criteria by Mahoney. So, so it gives you a list of drugs by system that you need to start. So, for example, in cardiovascular, it will tell you if somebody's got atrial fibrillation, then you need to think about risk control, but you also need to think about anticoagulation to reduce the risk of stroke. But in the same vein, it will tell you if you've got, patients with dementia, really, you should be avoiding prescribing antipsychotics. So it's very good. It looks at things by system. and I would direct you to a presentation by Mahoney. If you just Google start-stop criteria, British Geriatric Society, Mahoney et al., their presentation that they gave to the BGS a couple of years ago will come up, and it's a good reference point. And then you've got the latest American Geriatric Society BIAS criteria. So it identifies medicines for which the risks of use really outweigh the benefits. But the important thing about all these tools is they do not supersede clinical judgments. So you need to marry them with your clinical judgments. That's a really, really important thing to do. So for example, it will tell you avoid the first generation antihistamines because they have a high anticholinergic burden. There's increased risk of falls and delirium. Obviously, avoid nitrofurantoin if somebody's got a low creatinine clearance because it can cause problems, pulmonary fibrosis, liver fibrosis, hepatotoxicity, peripheral neuropathy, for example. You shouldn't be using aspirin for primary prevention. So you should be using it for secondary prevention. So the patient who lives down the road and say, well, John next door is taking aspirin, so I thought it might be good for me, so I'm also taking aspirin, shouldn't be taking aspirin for primary prevention. These days now, we don't really use warfarin, for PEs and DVTs for thromboembolism. We use DUACs. And even within the DUACs, we've got rivaroxaban, which causes a higher bleeding risk, in terms of intracerebral hemorrhage compared to the other DUACs. So for example, for me, I wouldn't use rivaroxaban in an older patient. I would use a apixaban, for example, or a doxaban, When I was a registrar, if you had a stroke on aspirin, you got put on dipyridamole. We don't use dipyridamole anymore. It causes orthostatic hypotension. It causes headaches, for example. Alpha blockers, we wouldn't use first line for treatment of hypertension because of the high risk of postural hypertension. D2, the centrally acting alpha agonists for hypertension. And digoxin, you've come across it in the BIAS criteria. You also come across it. You came across it in the Ottawa Top 10 tool. You also come across it here. And basically what it's saying, you should avoid using it for first line treatment, avoid first line for heart failure. But if you do use it, don't use doses above 1 to 5 micrograms daily because it causes ditch toxicity. And then your patients present with a kind of laissez-faire kind of clinical presentation. So they might be a little bit confused. They might have a bit of nausea. They might have maybe some vomiting. Somebody might think they've got a UTI, for example, And then anticholinergics, amitriptyline is top of the list here. And I know you sometimes use this towards the end of life. And if you're using it for a short period towards the end of life for a particular symptom, that's fine, And then the first and second generation antipsychotics, barbiturates, benzodiazepines, as I said, the best thing is not to start unless there's a really clear indication. Perhaps the patient's got seizures or they've got another condition, where they need to have it. So you can see there's a whole list of medicines. I'm not going to go through all of them. I've put them mainly for reference, so you don't have to pay to get the American Geriatric Society BIAS criteria, which costs about $5. And you can see here anticholinergics come up again and it tells you drugs to avoid in patients with dementia, drugs to avoid in patients with Parkinson's disease. Obviously, if somebody's had a duodenal ulcer, you don't really want to be giving them aspirin or a non-steroidal. I love the saying by Doug Danworth. It says, and I quote, starting medicines is like the bliss of marriage and stopping them is like the agony of divorce. We don't like stopping medicines, or we say, well, it was prescribed by somebody in a teaching hospital some 25 years ago, so we don't really want to interfere with it. I interfere with people's medicines all the time because I look at somebody holistically, which is what we should be doing. And MedStopper is brilliant. If you're not sure whether you need to stop a medicine just in finito like that, or you need to win it down, MedStopper is your go-to, medstopper.com. You click frail elderly, or whether if they're not frail elderly, you unclick that. You type in the medicines, in this case, amitriptyline, and then it tells you, whether it causes harm, but it also gives you a tapering approach. But more important is it gives you possible symptoms if you are stopping or tapering, things to watch out for. So for example, if you're deprescribing amitriptyline, you want to watch out for cramping, diarrhea, nausea, hot flushes, cold flushes, sweating, etc. And actually this is something you can print out, particularly in an outpatient setting, and give it to the son, the daughter, the granddaughter, the patients themselves to say, actually, I've cut your amitriptyline down from 100 milligrams to 90 milligrams. And then after a week, I want you to do X, Y, Z. But actually, if you start getting these symptoms, just let my receptionist at Pottersburg Community Hospital know. And then it means that I have to slow down a bit with the tapering and I will call you back. So very simple, very straightforward. This is the one I use in my everyday clinical practice. In general, if a drug acts on the brain, you probably need to wean it off rather than just stopping it. And then you've got stop frail. So what is stop frail? It's a practical patient-centered tool that you can use to approach the prescribing decisions in older people approaching the end of life. Because actually, it's not just about treat. We have duties beyond restoration and maintenance of health, especially when patients have a poor 1-year survival prognosis. And I put the reference there, as you can see, in Aging from March 2021, if you want to go and look at the article. But basically, the criteria is if somebody's got really poor activities of daily living, they've got severe chronic disease and or terminal illness, they've got severe irreversible frailty, and you that are looking after the patient would not be surprised if they died in the next 12 months, then stop frail is really useful because it gives you a list of potential inappropriate prescribing indicators. So this is the busy bit, but just concentrate on the color codes by the side on your right side. So if a patient is not taking a particular drug persistently, not taking a particular medicine persistently, despite adequate education, and you've considered all the formulations, liquid, suspension, under the tongue, etc., and they're still not taking it, then you should stop it. If the drug has no clear indication, you should stop it. If they're taking a drug or medicine for symptoms that have been resolved, such as pain, nausea, vertigo, pruritus, they used to take it, but it's now resolved, then stop it. Lipid-lowering therapies, statins, antiplatelets for primary prevention, neuroleptic in dementia. PPIs is a huge problem. You come across loads of patients with PPIs. We did some work in our community hospital. 50% of the patients on PPIs, we could not work out why they were on a PPI. In fact, one guy was still taking omeprazole despite having a malarivice tear 20 years previously. He says, nobody told me to stop it. It's been represcribed and represcribed. So always ask, if your patient is not on a high-risk medicines that cause bleeding, then the PPIs can be reduced. And we'll talk about that in a moment or so. Then the thiophylline have no place in managing COPD. Then obviously NSAIDs you need to be careful about. We've spoken about anticholinergics, we've spoken about anti-diabetic medicines. And actually people take, in West Africa, your parents go and see their doctor. When they come out, if they don't have folic acid and multivitamins, then, they've not prescribed enough. Give people good food, proper food. Then they won't need all these multivitamins and stuff. Okay. And then this is the ONC-PAL Deprescribing guideline. So aspirin is there again. Statins come again, lipid-lowering medicines. Blood pressure-lowering medicines come. Anti-ulcer medicines, PPIs, all hypoglycemics, osteoporosis medicines, vitamins and minerals. So very, very similar to stop frail. You almost think that it might be the same authors, but there are two different author groups here, that have looked at this. And then people say, well, Cliff, you're asking us to stop medicines, but there's guidance for prescribing, but there's no deprescribing guidance. Well, not anymore. Deprescribing.org is at your door. And they have deprescribing guidance for PPIs, tricyclics, benzodiazepines, Z drugs, benzodiazepine receptor agonists, antipsychotics, for example, cholinesterase inhibitors. And this is really important. And they've got an app as well, lest I say that, and you can download that onto your smartphones. So for example, this is an example of one of the algorithms. I don't know why my patient is on a PPI, okay? Well, they're taking 40 milligrams of omeprazole. Let me reduce it to 20. Okay, still no problems. Let's reduce it to 10. Monitor at 4 weeks and 3 months. Still no problems. Let's reduce it to a pill in the pocket approach, but also use non-drug approaches. So don't have late meals. Elevate your head off your bed. Do you need to lose weight? Are there any diets, spicy foods that cause? Can you use over-the-counter antacids or just use your PPIs over the counter or things like Gaviscon, to manage occasional symptoms? Brilliant. We've been able to significantly reduce our PPI prescribing in our patients in the community hospital. And then, so you remember the first two things I said is bring the medication. So you need to have that list. Yeah, that's the first thing. And then you judge the medications to see which ones are candidates for deprescribing. Then the third thing you do is you plan the prescribing of the patient and of the carer based on what matters to the patient. So you want to go from a plate full of medication to something like this. And then you develop and implement the plan. And obviously, sometimes you get hiccups. You might need to increase the dose. You might need to taper over a longer period, but that's all part of it. So what matters to you? Well, I tell you what matters to me. Family matters to me. Going on my holidays really matters to me. I'm a big Man U fan. That matters to me. So what matters to your patients? What are the things they'd like to be able to do that their health stops them from doing? So there's one of my patients who says, Dr. Lisk, you know, if you can improve my walking to an extent that I can walk down to my shed at the bottom of my garden, I'll make a wooden carving for you. What symptoms do you want your treatments to help with most? How important to you are the treatments of your current symptoms, i.e. your pain, your itching, your incontinence, versus treatments related to risk of future illness, i.e. your statins for reducing cardiovascular risk? Do you think you're having medicines from that? Do you think you're having side effects from the medicines? Which medicines have you identified that actually you want to stop because it's causing you problems? Do you take your medicines in ways that you find much more useful for you and much more helpful than what the instructions on the label say? These are all things that you need to take into account when you're talking to your patients. And in terms of shared decision making, I'll point you to this YouTube video. And so just to give you a quick synopsis, it's about the son of a patient who has got severe Alzheimer's, and they're having a discussion with their medical practitioner about reducing, stopping, or giving a drug holiday from Aricept. And really, it's the epitome of shared decision making. You know, have a look at it in your own time. So people say, well, Cliff, you see all this. Okay, now you've provided a website that shows, you know, some guidance for deprescribing, some deprescribing guidance. But what is the evidence? But one of the things I get asked about a lot is statins. So this is a really good paper published in JAMA, The Safety and Benefits of Discontinuing Statins in the Setting of Advanced and Self-Limiting Illness. So no change in 60-day mortality, better quality of life. Some patients experienced some cardiovascular events, few patients, and there were cost savings, about $716 per patient. So you can go and have a look at that paper. Really good paper. Benefits and harms, withdrawal of antipsychotics. We know we don't do this very well. People leave hospital because they have been put on antipsychotics because maybe they had a really, really severe delirium that they couldn't just manage with one-to-ones. But we give no information to the general practitioners about what they should do. You know, and we know you could successfully discontinue antipsychotics with little to no effects on behavioral or psychological symptoms and cognitive function. And this is really good. You know, Cochrane came up, you know, with reviews of deprescribing specific medication classes. And I would point you to that as part of your reading. So there are loads of trials, there are loads of studies with huge numbers. Look, 404, 3,000, almost 4,000 patients, 5,691, and they all include some degree of education like we're doing now, maybe some template for medication rules, maybe some clinical decision support systems, plus or minus medication review by a pharmacist or physician, plus or minus physician and clinician education. And we know it reduces potential inappropriate medicines prescribing, it reduces number of medicines, it increases the prescribing, you know, it reduces prescribing of potential inappropriate medicines. But no reports in self-reported patient outcomes or adverse drug reactions or cause death or rehospitalizations. So people say, well, what's the point? And this is a really, really good paper. You know, so establishing the worth of deprescribing inappropriate medicines, are we there yet? Well, although recent deprescribing trials do not conclude improvements in clinical outcomes, but we can see it though in our day-to-day patients less confused, they fall less. So we all have stories that we can tell where patients have improved who are, you know, potentially dying, you know, and like Lazarus, they've risen from the dead, you know. But these studies have actually signaled areas of innovation and offered insights into designing future trials to establish the worth of deprescribing. We're not there yet, but we're making progress. And you might wonder why you got a picture of mouse in this presentation. So this is a piece of work that was published in the Geriatric Society of America. And what they did was they gave loads and loads of medicines to a mouse. And what happened was, as the drug burden index increased, the mice became much more frail. They became less mobile. They had less strength. They couldn't walk. They couldn't do the things that they normally would do. Once they started deprescribing, a number of these outcomes were reversed. So this fits in very well because we know that people with polypharmacy are 1.5 times more likely to develop frailty. And if they've got excessive polypharmacy, more than twice more likely to develop frailty. So it stands to reason that actually, if you're thinking about the polypharmacy mouse model, that if you start reducing things, you know, you might improve somebody's quality of life, you reduce their pill burden, you might make them better. Okay. I know it's a bit of a stretch comparing mice with humans, but you can see where the trend in certain research and deprescribing is going. What about physicians' perspectives on deprescribing? So this was a study that was published in JAG, looking at geriatricians, general physicians, and cardiologists. What were the top 5 reasons why they deprescribed? Adverse drug reactions, limited benefits given limited lifespan, and you can see geriatricians are very good at doing that in comparison to general physicians and cardiologists. Concern of future adverse reactions, lack of indication, and unclear benefits because of limited clinical trial representation. And then there were other things: medication costs, concern about their medication management, patient is taking excessive amounts of medicines, excessive polypharmacy. And patients actually say, look, I'm taking too many medicines. I want to reduce the number of medicines I'm taking. But what are the barriers? So as I said earlier on, when I used the analogy about the teaching hospital, concern, you know, Dr. X started this 15 years ago. I don't really want to mess around with their medication. Patients' reluctance because they think actually stopping medicines, it might be because you want to kill them off. Lack of understanding of deprescribing. So that's why the communication is really important. Insufficient time. When we did some work locally, time came up a bit, and we did a lot of training of our ward pharmacists and involved the discussions at board round level, which is really important. And then medical legal concerns. Oh, Dr. Lisk, my patient has high blood pressure, they've got postural hypertension. If I stop the blood pressure medicines and if I stop the blood pressure medicines and then they have a stroke, you know, that would be a problem medical legally. Well, if you don't stop it and then they fall and fracture their hip, or they hit their head, you'll have a problem. You know, then people talk about evidence, concerns about upsetting people. I'm not concerned about upsetting people. I'm concerned about doing what's right for that individual person. Time comes up again, limited training. Well, that's why we have sessions such as this. And in America, deprescribing is not reimbursable, so people don't get paid for doing it, so they don't really want to do it. Herbal medicines, this was work we did in our departments. We asked people, what herbal medicines have you come across? We asked them, first of all, do you ask about people's herbal medicines? And 99% of people didn't ask. I think only myself was the one that asked about whether people were taking herbal medicines and what they were taking. But actually, when we said, what herbal medicines have you come across in your clinical practice? Look at this. You know, ginkgo, garlic, ginseng, kava, ginger, valerian. Valerian was actually used in the First World War as an anxiolytic for injured soldiers on the battle lines. Feverfew, aloe vera, cranberry, hawthorn, you know, sopalmatu, Chinese herbal medicines. So you can see people come across a whole lot of things, but you don't ask. If you don't ask, people won't tell you because they think it's natural, you know, and some of these things have side effects. Some of these things interact with your conventional medicines. And my interest in herbal medicines dates back to when I was a med reg, and this is a reference for a piece of work we did. Herbal medicines, our working knowledge as geriatricians needs to be better, published in CME, Geriatric Medicine. But don't forget discontinuation symptoms. So as you stop stuff, people might get rebound symptoms, you know, and you can see here with diuretics, you might stop the fusimide 20 milligrams thinking, you know, they've just started it for leg swelling, and then you might find out that the patient actually has heart failure. Your patient's getting rebound tachycardia. So if you're stopping the beta blockers for postural hypertension, make sure they're not taking the beta blockers for AF rate control, for example. So I'll just give you a moment just to go through those very quickly. You can see antimuscarinic agents. So generally, as I said, if something is acting on the brain, then you probably need to wean it off. And I've put the reference there by Linda and Irene. I've used their slides with permission. Tips for deprescribing in a nursing home. Really, really good paper. So, what are my takeaways? Got plenty of time for discussion. Make a diagnosis before initiating treatment. When you prescribe, carefully weigh up the risks and benefits. If you're prescribing, start low, go slow, sometimes say no, because actually I can't increase that ACE inhibitor because actually the patient has a systolic blood pressure of 90, for example. Can't simplify medicines. With Parkinson's, it's a bit more difficult because we can't really simplify if the patient needs it 4 or 5 times a day. But most of the time I try and stick to once a day medicines. Makes it easier for medicine, for patients. So simplify the medicines. Think about if you were taking it. I struggle to take my once a week mefloquine when I go home to West Africa. And I'm expecting somebody who's on 20 different tablets, who may have some memory impairments, who might also be the carer for their spouse, to do all this and not forget. Always make sure if you think something is causing harm, stop it rather than just start another new medicine to treat the side effects. Always make sure you know what your patients are taking. If you don't know what your patients are taking, that consultation is not complete. That patient encounter is not complete. And thank goodness now for electronic systems, because one of the things that really used to irritate me was when you go on a ward and they say the drug chart is in pharmacy. Thank goodness that's now a thing in the past because it's on the tablets you're going around with. Always suspect medicines. Remember your tools, but also remember your clinical judgment. Don't be afraid to stop stuff. Don't be afraid to stop more than one medicine. Educate patients, their carers, their relatives regarding medicines, potential reactions, why you're trying to do what you're doing. Don't withhold appropriate therapy, but at the same time, you've got to really reconsider medicines at the end of life. And finally, evidence-based medicine does not mean everything that has ever been proven some benefit must be done. And certainly not in the groups of patients you and I look after. Whilst P less than 0.05 might be extremely important to write the clinical paper, I would argue that clinical relevance is much more important. Clinical relevance. What matters to your patient? And what can you do to them to meet what matters to them? And I'll stop there because I can stop for Africa. I've got some homework for you. We've got about 8 minutes or so to take questions. And obviously, if you put your stuff in the chat in terms of what you've learned today, that would be really useful. Thank you very much for listening.
Wow. Thank you so much, Cliff. I have learned loads, and I think a lot about deprescribing. I remember from a long time ago doing an audit of people coming in to the hospice with fatigue. And most of the fatigue was caused because their it was assumed to be due to cancer, but actually it was their blood pressure was too low because they were still on high dose beta blockers in the days of atenolol and etc. So, and that's because as people become frailer or iller, they stop taking their blood pressure because they stop, they can't get to the GP, district nurse visits, but doesn't do blood pressure. So there's so many lessons you've shared for us today. I've written lots down. I mean, the fact that we're causing frailty with our polypharmacy is such a key message.
Yeah.
We don't ask enough about herbal medicines. I love all your tools. We're going to look at MedStopper, I think.
Yeah.
And the kind of blurry paper. Yes, and I've never had a patient who is unhappy about stopping medicines.
No, so I haven't myself.
No.
It's quite fascinating, and actually, but actually from a clinician's perspective, it's quite heartening when actually you see somebody and you make some changes to their medicines and actually they get better.
Yes.
And even when people don't get better, say thank you so much, Cliff. My father is taking so much less medicines now. Medicines used to be a real chore for him. Now I know that what we're giving is what he actually needs at this point time T in his life. And I think that's really the message, and it would be different for each patient. So for example, I had a 90-year-old yesterday. We had a discussion. She had a fall where she fractured her olecranium. She's had surgery. She's on a statin. But really, you look at her, you think she's 75. Biologically, she's very good. So, and her life expectancy is probably at least 5 years. I wouldn't stop a statin in that person. At the same time, I have some 80-year-olds that are really frail that I look at them and think, I'm not even sure you're going to be here the next 6 months. And those, it might be appropriate for their statins to be stopped. You know, so you need to look at it as an independent patient's basis. You know, it's quite similar to my metastatic ovarian cancer example I used. You know, we left on a apixaban until she became unconscious, you know, because she had a wish not to get a stroke. And I completely acknowledge that risk. Stroke is the commonest cause of disability worldwide.
Yes, so we see massive overuse of PPIs when they're not all necessary, but we do have patients on non-steroidals for their pain and steroids. So we worry a bit about gastric bleeding, but again, it's about personalizing.
Absolutely.
One thing I wanted to ask you is, I often use lower doses than are recommended in the BNF, and
yeah.
You've talked about pharmacodynamics and kinetics. You know,
Yes.
things like metoclopramide, we're seeing increasing toxicity from, but we use it as a prokinetic, but seeing quite a lot of neurological side effects.
Yeah. So
yeah.
My second rule: start low, go slow.
Yes. So we should just start with low doses.
Yeah. Because your clinical, yeah, I mean, we've got a lot in common with our pediatric colleagues in older age medicine, loads in common, you know, and I think previously we've taken the attitude that, well, this is adult dose, so we're going to just use the adult dose. But increasingly, we're finding actually the adult dose for somebody who might weigh 40 kilograms or 50 kilograms might be too much for them. Yes. You know, so you then need to make allowances for that. So, I mean, I had a patient who got referred to my clinic under the 2-week wait because she was losing weight and had nausea, vomiting. They thought she had gastric cancer. And actually, it was ditch toxicity in the face of CKD stage 5, worsening CKD, but on the same dose, which was now toxic for her. And we stopped her digoxin, sent off DIG levels. DIG levels, I got phoned over the weekend, said the DIG levels were high. I said I suspected it might be high. And then 6 months later, patient had put on all the weight she had lost. Wow. It was just ditch toxicity over a long period of time. You know, so we all have stories where you've actually there's stuff that's happened and you think, oh wow, this is amazing.
So just be braver about lower doses, not titrating unless the underlying problem is getting worse.
Yeah.
Yeah.
If you're titrating, if you're also titrating, go slow.
Yeah.
You know, I myself and my cardiologist, we have, well, I wouldn't say a love-hate relationship, a love-love relationship, but, you know, they're always saying, increase the ACE. And I said, no, we're not increasing the ACE because the patient can't get out of bed. What's the point of reducing your cardiovascular risk if you can't get out of bed to enjoy the life? Yes,
that's true. And your message about creatinine clearance and not just looking at EGFR is important for us because we've got used to just looking at EGFR. We had a 102-year-old lady in recently who had advanced colon cancer, not very symptomatic. And we kept forgetting that her body and her kidneys are 102 years old, even though she was still driving. And we did over-sedate her with a low dose of something. And when we stopped it, she woke up again. Yeah. Yeah. And I mean, there's some really good comments here. I mean, Visnavia said there's a lot of anxiety in Geriatric. Absolutely. Because of not having the capacity to monitor. I mean, I one of the things I find actually, I've stopped just saying, please do this and expect it to happen because they don't have the time. So I do the roles of pharmacists. So I think pharmacists have any on here. Yes, pharmacists have a massive role here. There have been some really good examples of pharmacists and care homes. And I think those are places where actually medication costs can be significantly reduced that you can then implement back into services. So pharmacists, I have a pharmacist on my ward round in the community hospital. When CLCH took over, I said, there's just one thing I need from you. A pharmacist that's there when I'm there, not on the days when I'm not there, because that's no good to me or the pharmacist. And actually, we do a joint ward round. And actually, you know, when you're doing rounds, that competing interests, you know, you go there, the patient's got heart failure, they've got a pneumonia, they've got a DVT, and you're trying to sort everything out, you know, and then you might have a note from the daughter and you're trying to sort that out. And sometimes your mind strays a bit, you know, and it's quite nice having a pharmacist that says, Cliff, what about the statin? What about the anticholinergic? You know, and pharmacists, you have a good pharmacy, it's really worth their weight in gold. And your ACPs as well, that's really useful. I do a lot of monitoring through the phone. So I do my first face-to-face appointment and I say, do this. And then I phone in a couple of weeks
I always have 2 slots before my clinic starts at 9. One is at 8:15 and one is at 8:30. And that's a telephone appointment. And that's usually for my deprescribing actions.
Right. Well, we've had a lot of very welcome comments. It is 2:00, Cliff. You're going to share the PDF because there's so much information.
Yes, I will share the PDF. So I'll send
it round.
Yes, I'll send that through later this afternoon.
Thank you. We're going to go and review all our drug charts now.
That sounds good.
Good. Well, thank you so much again. I think everybody here has learned a lot, and yeah, amazing.
Absolute pleasure. Have a good one.
Thank you.
Thank you, Cliff.